Hello, my name is Jennifer Stransko, and I am the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Duffy Health Center for hosting today's session, ECG Mini-Series number 1, Basics and Heart Block with Dr. Charles Schulman. Dr. Schulman was an assistant clinical professor of medicine at Harvard Medical School from 1988 until 2016. He is currently a corresponding member of the faculty of Harvard Medical School and a senior physician at the Beth Israel Deaconess Medical Center in Boston. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And whenever you're ready, Dr. Schulman.
Thank you very much, Jennifer, and good afternoon, everybody. I hope things are doing well down on the Cape. I'm in Newton, so not too far from you. This is the first of a series of ECG talks. So there are 3 talks. This is number 1, and what I do is start with the basics, and we'll go from there. Why is it not advancing? Okay, now it's advancing. I have no disclosures, and you got some of this information from Jennifer already. This is approved for category 1 credit, but you must complete the after lecture feedback. Learning objectives for this session, including the anatomy and blood supply of the cardiac conduction system, understanding the formation of the clinical ECG and axis in the frontal plane, and recognizing normal rhythm, bundle branch block, and heart block. In subsequent talks, we'll cover ST and T wave abnormalities and arrhythmias, but not today. So we start with Dr. Einthoven. Dr. Einthoven invented the ECG machine, the ECG or EKG in German, in 1902, for which he received the Nobel Prize in 1924. This is a picture of one of his subjects who does not look too happy with his hands in 2 buckets of saline. And this is what the contraption looked like in 1905. Again, hands in 2 buckets of hands and 1 foot in buckets of saline. Just as a to show you how far we've come, in 2024, you can record off of an ECG off of a wearable smartwatch, turn it into the standard ECG, and analyze it with artificial intelligence, and estimate left ventricular pump strength. This is all, brand new and for the future. But right now we're back in 2014 and having to care for our patients. So let's talk about it. I see that Lisa has raised her hand. I don't know if I'm supposed to do something about that.
I can unmute her if she wants to be unmuted.
Oh, okay, fine. Go ahead.
Oh, she said it was an error. Okay.
Oh,
That's Lisa Jones, Dr. Schulman.
Yeah, I see that. Okay. Okay. Hi, Lisa. Okay, so starting with the anatomy of the cardiac conduction system, the cardiac impulse starts at the SA node, the sinoauricular node, which is located at the junction of the right atrium and the superior vena cava. Impulses travel through the atria to the AV node, over something called Bachman's bundle. And at the AV node, there's a kind of a pause, and then the impulse travels into what's called the common bundle or His bundle, and then the bundle branches and the His Purkinje system. The blood supply of these structures is as follows. The SA node receives its blood supply in 60% of people from the right coronary artery and 40% from the left coronary artery. The AV node receives its blood supply in 90% of people from the right coronary artery and 10% from the left circ. The right bundle and the anterior fascicle of the left bundle are fed by the LAD, and the posterior fascicle of the left bundle receives a mixed contribution. This just highlights the concept of vectors and how they relate to what we see on the electrocardiogram. So when the electrical vector travels toward the exploring electrode, on the clinical electrocardiogram, we see a positive deflection, whereas when it travels away, we see a negative deflection. And so we can determine direction of these vectors, and we'll talk about that in a little while. So this shows how, what we see on the electrocardiogram, on the clinical electrocardiogram, as the electrical impulses travel from SA node to AV node and then to the ventricles. So the SA node does not cause a deviation from the baseline. As the impulse travels through the atrium, it writes a P wave. So atrial depolarization is a P wave. Then there's the PR segment, which is the pause at the AV node, which it does not cause a deviation. And then the QRS complex reflects depolarization of the ventricles. The ST segment and T waves represent repolarization on the clinical electrocardiogram. This is what's called Einthoven's triangle. Right? Dr. Einthoven figured this out years ago. And so this shows what are called the bipolar leads. So lead one is positive in the left arm and negative in the right arm. That's a bipolar lead. The lead two is negative in the right arm and positive in the leg. Lead three is negative in the left arm and positive in the leg. The AVR, AVL, and AVF have a central 0 point, so that AVR is from the center to the right arm, AVL center to the left arm, and AVF to the leg. So here's a little quiz. Here's a little problem that relates to what I just told you. Here's an ECG that the computer said had atrial flutter with 4-to-1 AV block. Is that true? Can you tell? Well, the answer is this is not an atrial flutter with 4-to-1 AV block. And the way you can tell is that these things that look like they might be atrial flutter are seen in leads 1 and 2, but not in lead 3. These are simultaneous. So lead 3 clearly shows sinus rhythm. So this is sinus rhythm in a person who has a tremor. And so the question becomes, which arm has the tremor? Right, left, or both? And here's how we can figure out the answer from Einthoven's triangle. So Einthoven's triangle involves the right arm and the left arm that has one of them, one or both have a tremor. Lead 2 is the right arm and the leg that has a tremor. Lead 3 is the left arm and the leg, and that does not have a tremor. So which arm has the tremor? The answer is the right arm. This shows the chest leads. Einthoven's triangle and leads AVR, AVL, AVF are in the what's called the frontal plane. The chest leads are in the horizontal plane. V1, 2, 3, 4, 5, 6 across the chest. V1 is located to the right of the sternum. The others are located to the left of the sternum. And the impulse, the initial part of the QRS travels from left to right across the septum so that you can have an R wave, a positive deflection, an R wave in lead V1, and a negative deflection or Q wave in lead V6. Then, as it go across the chest leads, the R waves progress, right? So this is called R wave progression across the anterior precordium. The peak is either V4 or V5. And this is how we calculate axis. Okay. My recommendation for the simplest way to do this is to look at leads 1 and AVF. 1 represents the horizontal, AVF represents the vertical. And if you look at those two leads, you can figure out the axis pretty quickly. This is normal. This is right axis deviation. This is left axis deviation. And this is called extreme axis deviation or northwest axis. And this is a picture of the Seattle Space Needle to illustrate northwest axis. We take a systemic approach to analyzing an ECG. There are 6 parameters in the descriptive analysis: rate, rhythm, the intervals, PR interval, QRS interval, QT interval, the axis, whether or not there's chamber enlargement or hypertrophy, and whether or not there are changes of ischemia or infarction. This is how you determine rate, rhythm, and the intervals. Okay, so the standard speed, paper speed, is 25 millimeters a second. That's all ECG machines are set to that. Sometimes the machine is set to 50, and the ECG looks like really weird. But the standard is 25 millimeters a second. Each small box represents 40 milliseconds or 0.04 seconds. Each large box represents 200 milliseconds or 0.2 seconds. And you can calculate rate this way. If you put, if you started at the one part of a QRS, you can determine by counting boxes how fast the rate is. So if the next QRS is here, the rate is 300. If it's here, it's 150, 100, 75, 60, 50, and 43. Okay. As far as intervals are concerned, the PR interval ought to be 200 milliseconds or less. QRS should be 120 milliseconds or less. QT interval should be 470 in men, under 470 in men and 480 in women. Okay, here's a normal ECG. So we start by describing the rate and the rhythm. The rate is normal. The rhythm is sinus rhythm. You have positive P waves in 1 and 2, and AVF, meaning that the atrial depolarization is traveling away from the right arm and toward the left arm and toward the foot. That is, it's traveling downward in that direction. Okay, so that's sinus rhythm. The rate is 300, 150, 100. So the rate on this is probably 95. The PR interval is normal, the QRS interval is normal, the QT interval is less than 400 milliseconds, and T waves are upright and normal. Here's another one, which is also normal, but you'll notice here that there are Q waves in 2-3 and AVF, 2-3 and AVF, and out laterally. Now, remember I said that the initial depolarization traveled from left to right. So you could have, depending on the exact orientation, a positive deflection in V1 on the right and negative deflections laterally. Okay, these are tiny Q waves, and they're not pathologic. This is how you tell the difference. A pathologic Q wave would be wide and deep, which these are clearly not. Okay, so here we go. This is an ECG of a person who has, incidentally, a prolonged PR interval. You notice that? Greater than 200 milliseconds. It's a narrow complex, sinus rhythm. And what is the axis? Well, take lead 1. Count from here. So this is what? 5, 10, 13. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 13. Takes you over about here. AVF is negative by a little more than the same. So we're over here, and lead AVF is up here somewhere. And then you drop lines, and the axis turns out to be left axis deviation. It's up in here. Okay, here's another one. Here, lead 1 is negative. Right, +1 -4 puts it over here somewhere, and positive in AVF. So that puts the vector down here somewhere in right axis deviation. So this is right axis deviation. The other one was left axis deviation. Okay, now here is a strange looking ECG because there is what looks like a large Q wave in 1 in AVL, or 1 in AVL, and the P wave is negative in lead 1 and positive in lead AVR. Very strange. If you calculate the axis is actually it's along the horizontal, right? So this is about horizontal, and this is way negative. Is that a normal axis? The answer is no, it's not a normal axis. Do you know why? Well, let's look at the chest leads. Okay. Remember I told you about R wave progression. This is an example of a normal R wave progression, and this has normal R wave progression. So in fact, what the problem is a common problem that we see called reversed arm leads. If you reverse the right arm and the left arm, instead of lead 1 looking like this, it looks like this. And instead of AVL looking like this, it looks like this. You see what I mean? There's a, AVR doesn't, instead of looking like that, it looks like this. So in fact, these are reversed. This is his baseline ECG, and you notice that now the axis is about 0, okay, in the normal range, and AVR looks like a normal AVR, right? The basic impulse travels away from AVR and toward AVL, right? Instead of the other way around, right? So this is really AVR, this is really AVL. That's because the arm leads are reversed. Okay, now we have a problem here. When you hear hoofbeats on the roof on Christmas Eve, which is it more likely to be? Santa Claus's reindeer or a zebra? I'll let you answer that question for yourself. Although I have to tell you that I can't ask this question in South Africa because there are so many zebras. But there are so few zebras around here that we use the term zebra to refer to a rare condition. And so here is a 66-year-old man who presented with a 3-day history of cough, congestion, and pain in his chest. And lo and behold, his lead 1 and lead ABL look like the other fellow. Okay, so the axis here is again markedly to the right. Okay, except look at the chest leads. Instead of our wave progression that progresses like this, the R waves get smaller and smaller as you go across the chest. What do you think caused that? Answer? Dextrocardia. The heart is located on the right side of the chest. Okay, so that's my zebra for you. All right, so onward. This is bundle. This is a review of bundle branch anatomy and bundle branch block. Okay, so we have the AB node, the common bundle or His bundle, the right bundle, the left bundle. There's the common part of the left bundle and the left that has 2 branches, an anterior fascicle and a posterior fascicle. This shows the anterior on top of the posterior, but actually they are oriented like this in the chest. So when you try to draw a flat diagram, you don't really appreciate the actual location. Right? So this is right bundle branch block and left bundle branch. These are the characteristics, and these are the 2 leads where you should look in order to make this diagnosis. Basically, lead V1. And lead 1, standard right bundle branch block, has an initial R wave, then followed by an S wave. So this is the normal part. And then secondarily, the impulse travels back to the right. So, right, remember, V1 is located on the right side of the chest. So the dominant abnormal wave is to the right. As compared to left bundle branch block, where the dominant wave is negative or to the left, totally to the left, with a wide complex and perhaps a splintering. Okay, the fast and easy way to figure out whether it's right bundle branch block or left bundle branch block is that if you look in V1, right is up, left is down. And that's not difficult to envision, particularly since you know that V1 is located on the right side of the chest, and the abnormal deflection goes to the right, right bundle and away from the right and left bundle. So here's another ECG, has a wide complex, has normal sinus rhythm. The rate is 300, 150, 175, 60. It's a little under 60. Normal P waves. And an RSR prime in V1. Which bundle is this? Right or left? The answer is right. Are we getting answers in the chat? I haven't been looking at it. Yep.
Yeah, there was a couple people that said right.
Yep. Okay, good. I haven't been watching the chat, so okay. All right. And here we go. Here's the next. Oh, come on. Okay, here's the next one. Again, wide complex, greater than 120 milliseconds. This is the appearance in V1, with splintered in V6. And is this right or left bundle? You want to put answers in the chat? Let's see how you left bundle. Right, correct. Not right, correct. Correct. Okay. Here we go. Okay, here's a funny looking one. This is an asymptomatic 36-year-old man. And I'll look over here. It's got sort of a right bundle, right? But you notice that the QRS is wide, but the PR interval is extremely short, and there's this slurred upstroke. See that? This is a condition called WPW, Wolff-Parkinson-White syndrome. It's pre-excitation because there's an accessory pathway that's not down the AV node. So this illustrates the difference. So here's the normal impulse traveling through the AV node and depolarizing the ventricles, and so you have a P wave and a PR interval, and then the QRS. When the impulse travels down the accessory pathway, okay, it bypasses the AV node and it depolarizes the ventricle early, and that's why you get this wide slurred delta wave, which comes right on top of the P wave. Okay, there's a picture of Doctors Wolff, Parkinson, and White. Wolff and White were from Boston. Wolff was from Beth Israel Hospital. Beth Israel Hospital in those days. White was from the MGH and is particularly well known because he started an organization of cardiologists in Boston, which joined some other groups and eventually became the American Heart Association. So he's well known as or is thought to be the quote father of American cardiology. Okay, if you travel along the bike paths along the Charles River, there's a sign that says Paul Dudley White Bike Path. That's because he used to ride his bicycle from Belmont to the Mass General. Okay, now we turn to heart block, and we start off with the heart block poem. If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a Wenke Bach. If some P's don't get through, then you have a Mobitz 2. If P's and Q's don't agree, then you have the third degree. And that's useful to remember. Oh, somebody raised their hand. Yes? You want to unmute yourself? You have a question?
I just unmuted you, Christina. Christina?
Why don't you put your question in the chat, Christina, and we'll answer it eventually. Okay, so all right. All right, so here is first degree AV block. All right, a long PR interval, more than 200 milliseconds. In this case, 200 and probably is close to 300 milliseconds. This one's even longer. Okay. So that's first degree AV block. We don't really call it block anymore. It's usually often or nowadays referred to as AV delay as opposed to actual block. Second degree AV block is a condition where some beats are conducted and some are not. Like here. Okay, some are conducted and some are not. So we have two rhythm strips. the top one and the bottom one, and there are non-conducted P waves, as you can see here and here. Okay, but one of these patients needs a pacemaker, and the question is which one? A or B? Put your answers in the chat. Okay.
Looks like everyone's responding with B.
Okay. You guys are on the ball. That's right. If you look at this, right, remember, a longer block, that's because it's Wenckebach. Here's this PR interval, here's this longer one, and here's a drop beat. Okay, on the other hand, this is Mobitz 2. It's either conducted or not conducted. This is an all or nothing phenomenon. Okay, this is classic Wenckebach. It's also called Mobitz 1. It was Dr. Mobitz who recognized the differences between Wenckebach conduction and or what the conduction pattern that was described by John A. Now called Mobitz 2. So here you have PR intervals of 210, 380, 540, drop beat. Okay, typical Wenckebach cycle. You'll notice also that the PR interval after the pause is shorter than the one before the pause. And that's because of relative refractoriness in the AV node. That's where Wenckebach takes place, in the AV node. Okay, so it's a function. It's a matter of functional refractoriness. On the other hand, Mobitz 2 conduction is all or nothing. It either conducts or it doesn't conduct. And the PR intervals are all the same. And that's because it takes place in the His-Purkinje system. Okay, so one of the ways you can try to tell the difference between Mobitz 1 and Mobitz 2, or Wenckebach and Mobitz 2, is to have the patient exercise. So this is a 69-year-old patient of mine. This actually is 10 years old already, 2013, more than 10 years old. He was having chest pain on exertion. We thought he might have angina pectoris, so we did a stress test. Okay, and here's his baseline ECG, which he had. This is what he had all the time. Okay, there's this PR interval, this longer PR interval, and the drop beat. So this is Wenckebach conduction. When he exercised on the stress test, look what happened. Conduction improved. Here's 1-to-1 conduction. No drop beats. You see? So conduction improves with Wenckebach, and it deteriorates with Mobitz 2. And this is one of the consequences of Mobitz 2, right? You have either conduction or not, or you do. And the PR intervals are all precisely the same. So that's the difference. And this person needs a pacemaker, and the patient in the second ECG, the B, needs a pacemaker as well. Okay, so this is third degree, or a complete AV block. And what you see is sinus rhythm at this rate, which is 300, 150, approximately 100, maybe a little less. And ventricular rate is 300, 150, 175, 60. It's in the high 50s, 55 or so. And you notice that there is no relationship between the P waves and the QRSs, right? And it's particularly evident when a P wave is right on top of the QRS. Here it's in the middle of the T wave. Here's another one in the middle of the T wave. Okay, here's another example of the same thing. Okay, now here's a patient This is a patient that was actually sent as an e-consult, a 58-year-old man who thought he had a pump problem. He also thought he had a clot in his heart, which he was treating with vitamins. I won't comment on that. But if you notice here, let's look at he's got which bundle? Right or left? The answer is right. Okay. So the ventricular rate is 300, 150, 100, 75, 60, 50, it's probably 45. So the escape rate is about 45, and you notice that the P waves seem to march right through. Here's one right on top of this. This is clearly not conducted. Okay, and over here. But look at this. This RR interval is shorter than all the others. What does that mean? That means that there must be some conduction here, because the RR interval is shorter. Now, it's not very good. Most of the time, he has he has a ventricular rhythm, but there is some conduction. So it's not total and complete, but it's certainly high grade, and he needs a pacemaker to fix his pump problem, which is really a problem of not enough heartbeats. He would not be able to increase his heart rate if he walked up the stairs, for instance. That's part of the problem. Okay, so here we have another one, and let's look at this. Okay, sinus rhythm. It's sinus bradycardia, but sinus rhythm. And then a pause. What's the cause of the pause? Can you see it? Right there. So the next P wave, which ought to be about here somewhere, is not. There's a premature P wave. And this is a blocked PAC, which is the cause of the pause. A common cause of the pause, but not heart block. All right, and I think this is our final case. An elderly woman who presented with syncope and then complained of chest discomfort. Here's her electrocardiogram. This is actually an ambulance electrocardiogram. Okay, it says here supraventricular bradycardia, which is well, we'll find out. Here are what look like sinus P waves, and what's the heart rate? 300. 150, it's about 140. So this is actually sinus tachycardia, right? Sinus tachycardia with what? With heart block, right? With complete heart block here. These P waves are kind of marching through with no relationship to the QRSs. Okay. What is the cause? The cause is, if you look here at leads 2, 3, and AVF, there is ST elevation consistent with a STEMI, an ST elevation MI. Yes. This is an inferior MI. If the ST elevation in an inferior MI is greater in lead 3 than lead 2, that means it's the right coronary artery. And what relationship does the what ischemia of the right coronary artery have to do with heart block? Well, that's because in 90% of people, the right coronary artery feeds the AV nodal artery. So this is the result of AV nodal ischemia. In inferior MIs, AV nodal ischemia usually is transient, and you usually don't have to put in a pacemaker. That's different for anterior MIs. In anterior MIs with heart block, it's usually due to the size of the infarct as opposed to AV nodal ischemia. So if this person got a stent in their right coronary artery, the heart block would go away. Okay, and with that, I'll leave you only with some advice from Boston. Although on the Cape, it would be very similar, actually, for the pandemic. Thank you very much, and I'll be glad to take questions. Questions, anybody?
I don't see any questions yet. I see a lot of thank yous.
Okay, well, that's
And I'm
fine. I
posting.
appreciate that. I
Yes.
appreciate that. Thank you. Thank you. We're happy to do these sessions. We're happy to do mentoring, through MAVEN. So if you'd like to take advantage of some of that, please feel free to let us know.
Yes, I did put some information in the chat about mentoring. And then I also put a reminder about the CME survey that it'll appear in a tab when you close out of this webinar. So we just really appreciate you taking a few minutes to complete this. Not only does it give you the CME credit, but also helps us to plan the best session for you. And we share the feedback anonymously with the speakers. So we greatly appreciate you taking time to do that. Yeah, to see a lot of thank yous. Thank you, very informative. Thank you for the excellent review. Great as always.
Glad to help everybody.
Okay, well, thank you so much, Dr. Schulman. I really appreciate it. It was a really great presentation, and I hope everybody has a wonderful rest of your day.
Take care.
Okay, bye-bye.